Good evening and welcome to session 1 of our Tuesday group studies session for CPT. We're going to introduce the steps to solve a CPC exam case study for the CPC exam. And introducing our wonderful assistant, Mr. Sandy.
Good evening, Ms. Josie. Good evening, Mrs. J, Miss Eva, and to our fabulous intern team. And good evening to you all coders. Welcome you all to the first session of the group study by AMCI. Myself, Sandeep, joining you from Abu Dhabi. Please forgive me for my voice. I was down with a fever for last 2 days. But you know what? There was no way I was going to allow it from stopping me attending this class. So happy coding, everyone.
Yes, happy coding, and thank you, Mr. Sandeep, for being here. We appreciate you. And also, we appreciate the coders. We're going to go on now to Miss Eva. Please come and say
Hi,
hello to the
coders.
coders.
Hi, coders. Welcome to week 1 of the study group for the CPC course. And I'm so happy to be here with you guys, and I will be in the chat.
Thank you, Miss Eva. And last but not least, our curriculum director and lead instructor, Mrs. J.
Hello, how are you? Everybody good? We have a very large class today. So I'm excited. You're going to learn a lot. So let's get started, but not without introducing the interns. Take it away, Miss Josie.
Thank you. And we're going to present our new interns. I'm happy to announce this. Very excited for all of you. Miss Anubaba, you can come out and say hello.
Hi, coders. Warm welcome you all. And hi, Mrs. J, Mr. Sandeep, Miss Josie, and all the interns. I'm very glad to be here. I will see you in the chat. Bye.
We're glad to have you. Thank you. Miss Carla, you can take yourself up.
Excuse me. I'm sorry, Miss Josie. Welcome, all the interns. Hello to Miss Eva, Mr. Sandy, Miss J. We all ready to get ready to code? Let's get it. Let's code.
Thank you, Miss Carla. Miss Courtney.
Hello, coders. Welcome to group study. We are super excited to have you here. Group study is awesome, and I think you're all going to have a lot of aha moments tonight and learn, and we will talk with you in the chat.
Glad to have you too, Miss Courtney. Miss Dolly.
Hi, coders. I'm looking forward to going through some fun scenarios and practice with you all, and I'll see you guys in the chat.
And I believe our other coders will join us next week. So we'll go ahead and move on, and we'll get started. Thank you.
All right. Thank you, team. Miss Josie, Miss Eva, Mr. Sandeep. Thank you so much for that dedication. And thank you, new interns. Welcome, welcome, welcome. I love the energy. I love you guys. I really do. I have never worked with so many interns, so I'm excited. Thank you so much for coming. All right. The goals of the presentation. Number 1, we're going to discuss integumentary scenarios. Number 2, musculoskeletal. And number 3, respiratory. Yes, in this class, in this group study, we are going to learn how to solve multiple choice case studies for the CPC exam. Case studies, in fact, at the same time, we're going to show you how to break down these large scenarios. We are going to help you not be intimidated. No way. I promise by the end of this 4-week session, you will be amazing. I know it. All right. So here are the steps. Step 1, you have to highlight your key terms. In this class, we use this method. If it's yellow, you'll use that for your diagnoses. You'll highlight in yellow. You'll use green for all procedures and pink for anything inclusive. So if you don't want to be redundant, so pink, if it's already said, put it in pink. If it's bundled, put it in pink. Number 2, document your inventory, your procedures, diagnoses, signs and symptoms. Then you select your principal diagnosis or first listed diagnosis, principal procedure. Step 3, review all guidelines. And step 4, select the code that best matches your inventory list. I'm gonna let that marinate. Highlight your key terms, yellow, green, pink. Number 2, you're going to inventory. We've been doing this in class. Write down your diagnoses, signs and symptoms, and procedures. Then select which are principal or first listed. In this case, I think first listed is more appropriate. Number 3, review guidelines. 4, select the code that best matches your inventory. Now, as we've gone through this group study, we've kind of nailed or identified some things that you don't need to highlight at all. The reason you don't need to is because you're not going to code for it. And that means that's time saved. So number 1, don't highlight things observed by the physician. Number 2, don't highlight closures such as sutures, staples, etc. And I'm saying closures. Now you will code a suture if that is the treatment. But if you're just closing the surgical site, you don't highlight it unless it's for an integumentary procedure. Number 3, hemostasis or bleed control. Number 4, drains, surgical drains. 5, don't highlight irrigation of the surgical site. Number 6, don't highlight installation and removal of clamps and trocars. These items actually open up or help the surgical site stay in place, or they help retain, or keep it open so that the surgeon can see the surgical site. Number 7, dressings. Don't highlight those, and don't highlight surgical risks. Okay? Okay, Miss Josie, take it away. We're now in the musculoskeletal system section.
All right, Mrs. J. Ready, coders? Here we go. What are the CPT and ICD-10 CM codes are reported? A, 22514 M48.56XA. B, 22514 22515 times 2 M48.56XA. C, 22514 M48.56XA. Z87.311, Z98.890. D, 22514 22515 times 2 M48.56XA, Z87.311, Z98.890. Preoperative diagnosis, painful L2 vertebral non-traumatic compression fracture. Post-operative diagnosis, painful L2 vertebral non-traumatic compression fracture. Name of operation, L2 kyphoplasty. Findings preoperatively. She had compression fractures at T11 and L1, for which she previously underwent kyphoplasty. She initially had very good results, but then developed back pain once again. The repeat MRI 2 weeks later showed that she had fresh, high-intensity signal changes in the body of L2 and some scalloping of the superior end plate, consistent with compression fracture at L2. After some preoperative discussions and patients to see if she would get better, she was admitted to the hospital for L2 kyphoplasty. When she did not improve, at surgery, L2 had some scalloping of the superior end plate. Most of the softness was in the back part of the vertebral body. Procedure: the patient was taken to the operating room and placed under general endotracheal anesthesia in a supine position. She was then placed prone on the Jackson table, and her back was prepped and draped in the usual fashion. Using biplane image intensifiers, the skin incision sites were marked. 0.5 Marcaine with epinephrine was injected. Initially on the left side, a kyphon trocar was passed down to the superior lateral edge of the pedicle, through the pedicle, and into the vertebral body in the usual fashion. The drill was placed into the vertebral body, followed by kyphon bone tap. In a similar fashion, the same thing was done on the other side. Balloons were inflated uneventfully. The balloons then deflated and removed, and the cement, when it was in the doughy state, was injected into the sides in the usual fashion. This was done carefully and sequentially to make sure there were no cement extrusions, which after inspection there were none. There was a good fill to the vertebral body edges, up towards the superior end plate, and across the midline. The bone filling devices were removed and the trocars were removed. Pressure was applied, after which the skin was sutured with 4.0 nylon. Band-aids were applied, and she was taken to recovery in stable condition. Complications: there were no complications. Blood loss: minimal blood loss. Counts: sponge and needle counts were correct. What are the CPT and ICD-10 codes are reported? Hey, coders, we can give you another minute or so on this one, but most of you have them in.
All right. A lot of you took the deep dive. I know it's a lot of words, and sometimes things get convoluted. So, hopefully, if you have three different highlighters, it'll help you focus on what you need to focus on. If it's pink, you're not even going to really look at it. So, it just kind of moves it out of the way. All right. Great try, everybody. We have the alphabet going on in the chat, and that means we're going to have some aha moments. All right, post-operative diagnosis, painful L2 vertebral non-traumatic compression fracture. That's our diagnosis. Also, our procedure, L2 kyphoplasty. Findings: she had compression fractures at T11 and L1, for which she previously underwent a kyphoplasty. All right, she developed back pain once again. See, it's pink, back pain. Back pain is integral to symptom of these non-traumatic compression fracture. So it's pink. Just wanted to tell you that. Fresh high intensity signal changes at the body of L2. There was some scalloping consistent with a compression fracture. Then again, I mentioned L2 kyphoplasty. It's pink because we've already highlighted it green. Also, general endotracheal anesthesia, patient placed prone, skin incision, epinephrine injected, a, a kyphon trocar. We didn't even need to highlight that according to our instructions. Drill was placed in the vertebral body, kyphon bone tamp, balloons were infiltrated, balloons were deflated, removed, and cement was injected into the two sides. Bone filling devices were removed. Sorry about that. And that's all I have. There were no complications, minimal blah, blah. That's it. All right. So hopefully you have the same or something similar. And remember, if it's yours, if it speaks to you, it is good. All right. Okay. So just wanted to give you a visual of what a compression fracture looked like. And I tried to get an L2. I don't think it's L2, but work with me. So this is a compression fracture. Yes. And this is a um, I'm going to say bone weakening due to osteoporosis because they said it was non-traumatic. All right. And the goal of the treatment, if you're coding for a vertebroplasty, the goal is to improve acute pain and function. However, a kyphoplasty improves acute pain and functions, and it restores vertebral height and decrease severity of spinal deformity. So kyphoplasty is a little more purposeful. So it wants to, I think, help. The goal is to help restore the function of that vertebral body. Now, this is how a kyphoplasty is typically performed. All right, so you have your needle going in. Sometimes that needle can act like a burrow, and in our scenario, there was some drilling. Also, at the end of that needle there's a balloon placed. Then, after the burrowing, the balloon is inflated. After the balloon is inflated, cement injected. And remember, we talked about that doughy stuff. And then it got hard. And when it got hard, it sets so the vertebra doesn't collapse. So it kind of restores the function of that vertebra. All right, so let's go back and let's review our task. We already highlighted our key terms. Number 2, we're going to inventory our procedures, signs and symptoms, diagnoses, and we'll specify which one are primary. So we have L2 kyphoplasty. That's the second lumbar. That's the only inventory that we have in terms of procedures. Now, in terms of diagnosis, I found a few things. The L2 vertebral non-traumatic compression fracture, of course, because it says it. And also I saw that this patient had a history of compression fractures at the T11 space and L1, just above L2, and had a previous kyphoplasty spine surgery. So I think that is pertinent to this encounter, right? Okay, so our primary procedure will be L2 kyphoplasty. Our primary diagnosis will be L2 vertebral non-traumatic compression fracture. If you all agree. But I also want to show you something. Why did I indicate that this patient had a history of compression fracture and status post kyphoplasty? It's important. It's important because if you recall the selection of your first listed code, that AMCI first listed code chart, if you go to guideline number 5, you're not supposed to code resolved conditions unless if they are pertinent to the encounter. And if they are pertinent to the encounter, make sure you use history codes for those past diagnoses pertinent to the encounter. All right, I just wanted to tell you that. And I also want to draw your attention to what we have to do. We're going to code for kyphoplasty of L2. That's only one segment, just to remind you. And our goal, we have to choose the best answer, select the code that best matches your inventory list. All right, so now let's get going with our codes. Oh, let's go back. I kind of went a little too fast. All right, so we eliminated something, and I wondered when it got eliminated. All right, so our code is here. And if you look, A, B, C, and D, all 4 share the same procedure code, 22513. The parent is a kyphoplasty. Okay, kyphoplasty of the lumbar spine. That's exactly what it is. In fact, it is one vertebral body of the lumbar spine, and we are only coding for one vertebral body. Also, 22515 is coding for each additional lumbar vertebral body. That's not applicable because we aren't coding for additional vertebral bodies. So we are going to eliminate any answer that's coding for the additional lumbar vertebral body, 22515. So if you look at B and D, they're coding for a whole lot of vertebral bodies. So we're going to get rid of B and D. And that leaves us with A and C. So I apologize for kind of getting a little ahead of myself. Now we're going to focus on coding for these history codes pertinent to the encounter. Now let's look and see. Both A and C are coding M48.56XA, same diagnosis code. So let's go ahead and find it. This is collapsed vertebra, not elsewhere classified lumbar region, M4856. And this is a 7-character code. We have to elongate this. And if we go up, A, initial encounter for fracture, I don't know about that. It could be, oh yeah, it is. The reason why we're using initial is because the patient is having surgery. Just thought I would tell you that it's still in the initial phase. All right, next, if we go down and we look at Z87.31 subcategory, this is the code for personal history of healed non-traumatic fracture, other pathological fracture. All right, so I think that's correct. They didn't specify the type, so I like the other one best. And finally, code Z89.890. This is other specified post-procedural states. So they're coding for a procedure, a post-procedural state that was specified. And yes, it was specified that this patient underwent a kyphoplasty previously. So yeah, we do need to code for it. So if we look at A is only coding for the procedure and the diagnosis, whereas C is coding for the procedure, the diagnosis, the history of personal history of a pathological fracture, as well as the status post of that procedure. So we're going to eliminate A, and C is our answer. All right, so I had to put my screen down. I couldn't see what you're saying in the chat. Let me know how you're doing. Absolutely. Somebody said, are we just coding for L2? Absolutely. And you know what? You see all those words on the screen in this scenario? Look at all those words. If you just really focus on the yellow and the green, that really is what you're coding for. You guys are doing amazing. Outstanding. All right, so the time is, we're kind of winding down. These scenarios are really big. So we'll probably get to 2 more. All right. All right, so we've got 1 more in the musculoskeletal section, then we'll head on over to respiratory. All right, so if you got that correct, outstanding. But if you learned something, that is priceless. All right, Miss Josie, take it away.
Sure. Okay, what are the CPT and ICD-10 CM codes are reported? A, 23616, modifier LT, S42.202A. B, 23630, modifier LT, 20932, S42.202A. C, 23615, modifier LT, 20932, 20900, S42.202A. D, 20630, modifier LT, 20932, 20900, S42.202A. Case 2, operative report. Preoperative diagnosis, comminuted left proximal humerus fracture. Postoperative diagnosis, comminuted left proximal humerus fracture. Operative procedure, open treatment of the left proximal humerus. Anesthesia is general. Implants, DePi Global FX, stem size 10 with a 48 by 15 humeral head. Indications, the patient is a 66-year-old female who sustained a traumatic severe comminuted proximal humerus fracture. The risks and benefits of the surgical procedure were discussed. She stated that she understood and desired to proceed. Description of procedure. On the day of the procedure, after obtaining informed consent, the patient was taken to the main operating room where she was prepped and draped in the usual sterile fashion, in beach chair position after administering general anesthesia. Standard deltopectoral approach was used. The cephalic vein was taken laterally with the deltoid. Dissection was carried out down to the fracture site and the fracture was identified. The fragments were mobilized and the humeral head fragments were removed. Once this was done, the stem was prepared up to a size 10. A trial reduction was carried out with a DePi trial system and implant head. This gave good range of motion with good stability. Sutures down to and through the shaft were placed in key positions for closure of the tuberosities. The shaft was prepared and cement was injected into the shaft. The implant was placed. Once the cement was hardened, the head was placed on the Morse taper and then reduced. A bone graft was placed around the area where the tuberosities were being brought down. The tuberosities were tied down with a suture previously positioned. This gave excellent closure and coverage of the significant motion at the repair sites. The wound was thoroughly irrigated. The skin was closed with Vicryl over a drain and staples in the epidermis. A sterile dressing and sling were applied. The patient was taken to recovery in stable condition. There were no immediate complications. What are the CPT and ICD-10-CM codes are reported? We'll give you a minute on this one because a lot of you have it in. Thank you, coders.
Okay. We're kind of split here. I see some A's, C's. All right. Okay. And I see a few D's. All right. No B's. Let's do it. Okay, our keywords: the post-operative diagnosis, comminuted left proximal humerus fracture, open treatment of left proximal humerus. So that's our diagnosis and procedure. Then we had an implant, the DePi Global FX stem size 10 with a 48 by 5 humeral head. Okay, so the traumatic severe comminuted proximal humerus fracture, I'm going to make it pink because we've already got it here. Anesthesia was general. The cephalic vein was taken laterally with the deltoid. Dissection, this is how they carried it out. Fragments were mobilized, stem was prepared. Now we're talking about that implant. DePi, trial, stem and implant. I kind of am duplicating myself, but it's okay. Sutures, tuberosities, shaft was prepared, cement was injected into the shaft, implant was placed. Head was placed on Morse taper, reduction, reduced, bone graft. And sometimes when you don't know, you just don't know. So you do the best that you can. So I'm seeing these greens and I see that we have an implant. I also see reduction. I also see bone grafts. Do I have to code them all? Well, first, let's take a look at what happened. This patient had a comminuted fracture, and that refers to a bone that's broken in at least two places. We have avulsion fractures, and we just have this patient really did get a nice did a nice job on their shoulder. So it was broken in more than two places or more. And proximal, whenever you hear that term proximal, I know you already know, but if you don't, that means it's the closest point of attachment. So if the fracture is here, it's close to that point of attachment, which is your shoulder joint. If it's distal, it'll be further away from that shoulder joint. Just thought I would let you know. Now let's get back to our scenario. And we've highlighted our key terms. Now let's document our procedures. Well, we know that we have an open treatment of left proximal humerus. We have that DePi stem and implant. We have a reduction and a bone graft. The diagnosis, well, we have that comminuted left proximal humerus fracture. So that's going to be our primary or first listed diagnosis. And of course, the open treatment will be our principal or primary procedure. Everybody with me? Now, let's look at this DePi stem and implant and reduction and bone graft? Well, we know that a reduction is pretty much manipulation, the doctor putting that bone back into place. So we know that should be integral to our procedure, our treatment. It should be, and it is. But that bone graft, that too should be integral to your implant because your implant is also a graft. You know what I mean? So there's no need to code both. It is integral. And also, if you go to the graft section and you read the guidelines, it kind of tells you, hey, they're both grafts, so there's no need to code for them. An implant is going to do the trick of all. It's going to, the goal of an implant is to stabilize. So if they had to put some bone graft in, it's going to be bundled. So I encourage you to read your grafts or implants so that you know that often when you're coding for an implant, you do not have to code additionally for a bone graft. So just thought I would give you that. Now let's look at our families here. Oh, sorry about that. So I'm going to eliminate them, the reduction in bone graft, because they are integral. So if you look at B, it's coding for the bone graft because we just seen the code. And C is also coding for bone grafts. Two bone grafts at C. And so is D. So it's that simple. A is your answer. And a lot of you got that correct. And it is your job to select the code that best matches your inventory. But let's take a look at 23616. This is the parent says open treatment of proximal humeral surgical or anatomical neck fracture includes internal fixation when performed, includes repair of tuberosities when performed with proximal humeral prosthetic replacement. So that prosthesis, that implant is going to cover it all. Uh-oh. And I'm going to let that marinate for a moment. And we have 1 minute. And I typically don't like to go over. I don't because some people, they have things they need to do. But, and I'm not going to go over. We'll begin next week with respiratory. And I want to know, before we conclude, how you are. Was it easier than you thought? Or was it what you thought? Or was it harder? All right, so people said they're doing good. Someone said, hey, it's gotten easier. Someone said it's easier than I thought. Somebody said it was harder. Someone else said it was easier. Yeah, someone said lots of details. And my advice to the people that are kind of getting caught up with the big scenarios, just really look at the pink, which you're not going to code. Look at your green. You will code it if it's applicable, and your yellow. Wow. Good job, Sarah. Good job, Elizabeth, Madeline. Yeah, it is a lot of reading. Dawn, you got it right. Chun, chun, chun. And people say, hey, I need to look at my guidelines again. Yes, it is good to do that. And you all had an amazing night. So I just want to say so long. And I want to invite my team to come to the floor and say so long, Mr. Sandeep. Mr. Sandeep it's like 4 or 5 in the morning there. So I'm very, very grateful for him coming tonight. And would you like to say so long?
Yes, Mrs. J. I think they did pretty well today. Being the first class, they did an awesome job. There were some aha moments as well. So, Chorus, as you move along, I am sure that by the end of like session 8, you will get used to the techniques which we use, and you will be answering, and you will be getting the correct answer just like that. So, you will be doing it perfectly. So, that's it from me. So we will meet next week. Thank you for being here. Thank you, everyone. Thank you, team. Good night.
Thank
I'm good
you.
night. Yeah. Good night.
Thank you. I am just really at awe at his strength. I know I probably couldn't do it. So thank you so much, Mr. Sandeep, for coming. And Miss Eva, would you like to say so long?
Sure thing, Miss J. Hi, coders. You guys did amazing. It was a wonderful class. I really enjoy it. And I hope you guys did too. I will be seeing you guys on Saturday. Have a
Thank,
great rest of the week.
thank you so much, Miss Eva. And Miss Josie, would you like to say so long?
I would, Mrs. J. Thank you so much. Thank you, Mr. Sandeep, for that awesome presentation. Thank you, coders. You guys did worked really hard in the chat. I saw some improvement. You guys will get this. Just keep at it, keep practicing, and thank you, interns, for all your help in the chat. We really appreciate you. We can't do it without you.
Absolutely. Thank you so much, Miss Josie. And last but not least, I'm not going to have all the interns come up because that's a lot and it's late. I want to thank you, interns. They are students like you, and they were amazing in the chat. Thank you, thank you, thank you. See you all next week.